Morning, everyone. I'm Abigail Ribner. I work at Honor Health Vascular Surgery Group, and this morning I'm going to start the session off with a discussion of the epidemiology of PAD, diabetes, and amputation. And at the end, I'm going to discuss a little bit about how we at Honor Health have been revamping our limb salvage program. So although PAD is something that we all deal with on a day-to-day basis, unfortunately awareness in the general community seems to continue to be low. Back in the 90s, the partner study reported that 83% of patients, but only 49% of practitioners were actually aware of their PAD diagnosis. More recently, 61% of general practitioners did screen their patients for PAD, but only 6% were aware of evidence-based therapies. And in Europe, 25% of patients, only 25% of patients had revascularization procedures within a year of amputation. I think the big problem with this is that the screening guidelines for PAD remain a little wishy-washy. In 2018, the U.S. Preventative Task Force reported inconclusive evidence, essentially, around the screening for PAD. But the AHA does recommend an ABI for patients over 65 or those 50 to 64 with risk factors. On a more personal note, I'm not sure how many of you have seen this in your practices, but we've been seeing a lot of patients with the QuantiFlo test being done in the general community at employee health fairs and things like that. And we'll have patients come in very worried about very low numbers on those tests with absolutely no symptoms, palpable pulses. So I think as a community, we really have to make an effort to standardize this. Certainly, I think these QuantiFlo tests have a lot of room for improvement and maybe erring on the side of caution with continuing with the gold standard of ABIs. I think the other problem is that, we don't treat patients who are asymptomatic. And so the biggest push for us screening is really to get patients on an optimal medical therapy, while at the same time seeing patients as surgeons and explaining to them that just because an artery is blocked doesn't mean it has to be fixed. In terms of medication recommendations, there's class 1 evidence for antiplatelets and statin therapies, which are things that we certainly prescribe in our practices. Antihypertensive, we usually leave to the cardiologist or primary care docs, and then we're certainly very aggressive about working with our patients on their smoking cessation. In terms of the epidemiology of diabetes, you can see that there's been quite an increase in both the incidence and prevalence between the 90s and the 2010s. More recently, thankfully, there's been a bit of a plateau in the prevalence and decrease in the incidence. At the same time, though, you can see in this graph on the left that ongoing A1C surveillance is pretty poor, especially here in Arizona and the Southwest United States. And so, as we all know, the sequelae of diabetes compounds with time, and if these patients are not being monitored regularly, of course, that's going to end up manifesting itself with things like limb loss. In terms of the epidemiology of amputation, you can see on the right that the forefoot and toe amputations seem to be pretty stable, while overall more proximal amputations have continued to decrease. Interestingly, this does correlate with an increase in endovascular intervention and a mild decrease in open bypass procedures. I thought this graph on the left was particularly interesting given the large discrepancy between diagnostic lower extremity angiograms and those with intervention. I'm not sure if that was due to perhaps some being unindicated from the get-go or just disease so advanced that it was not amenable to endovascular intervention. In terms of the mortality, we all know that amputation is associated with very high risks of mortality, which again compounds over time. Reported data in the literature reports anywhere from 35 to 48% within a year of major amputation, and then up to from 40 to 70% at 5 years, historically with the highest rates among AKA patients, which is a well-known fact. However, more recently, there was actually a very interesting study that was published in the plastic surgery literature out of California that looked at 26,000 patients from 2007 to 2018, and this actually reported much improved rates in patients with amputations. On this graph, you can see that reported weighted averages over when they did a literature search are the yellow bars, whereas more recent data based on this study are the blue. Their hypothesis for this is that it's not the amputation itself that's killing patients, but rather the associated comorbidities. So if a patient's getting an amputation, that most likely means their disease is so advanced on a macrovascular level that their comorbidities such as CAD and cerebrovascular disease are also quite advanced, and that's truly what's causing the mortality. Hopefully we think that patients now with better medical management are not dying as much from these comorbidities. A well-known additional fact is that AKAs, again, are associated with higher rates of mortality. And as you can see here, they're showing that there was a statistically significant difference between the comorbidities in patients undergoing above-knee amputations versus below-knee, and this includes ischemic heart disease and cerebrovascular disease. Interestingly, they showed that patients who had diabetes and underwent amputation for PAD actually had lower rates of mortality, and their explanation for this is most likely that the data looked at all comers in terms of amputation, including toe amputations and TMAs. This most likely represents a more microvascular disease process, which is less likely to necessarily affect the coronary arteries or the cerebrovascular system. And so this was true up until the 5-year mark, where then patients who were seen to have diabetes most likely changed to a more severe form of macrovascular disease, which then correlated with higher rates of mortality. So just a couple minutes about our limb salvage. Honor Health is an interesting place because we have an employed vascular surgery community, but we also have a lot of private physicians, both in the vascular surgery realm, podiatrists, orthopedic surgeons, plastic surgeons. And so one of the things that we've observed is that a lot of our patients end up falling through the cracks. I'm not sure how true this is for a lot of people here in their institutions, but they would kind of ping pong in between wound care centers, vascular surgeons, going to different hospitals. And so we've really been trying to streamline this process where we have a catch-all for all of our patients to get plugged in, and so that we can continue to follow them and ensure they get the care they need. So there's a few different studies in the literature that have been looking at how to improve limb salvage programs in different communities. One of the most important things that they have looked at is the idea of a multidisciplinary team. So for sure, of course, wound care, podiatry, vascular, but also prosthetics, palliative, endocrinology, ID, et cetera, really trying to bring all these people together to work with these patients. Another important feature has been the use of the Wi-Fi and glass classification systems, the purpose of which is so that people in all different specialties can use one universal framework in order to predict a patient's risk for amputation and use that to communicate with other specialists. This is just an example of the glass guidelines that are used, and it divides it into the FemPop segment and the infrapopliteal segment, and again allows for a lot of different people across different specialties to define a patient's risk. So major considerations for developing a limb salvage program is good vascular imaging capabilities, most commonly ultrasound. You really want to have a lab where you can get same-day studies and studies across a broad breadth of diverse studies. Cross-sectional imaging, of course, looking at CTAs, and then block time, not just block time, is so that you have the ability to do these interventions, and interventions both on an open and an interventional basis, but also doing them in a timely fashion. So if a patient comes in on a Tuesday and your block time isn't until Monday, they're not sitting in the hospital for 6 days waiting for a revascularization procedure. Of course, the cost with any of these limb salvage programs can be higher, but we justify this by saying that in the reported literature, amputations are the 6th costliest surgery. Amputees are frequently admitted. There's obviously a reduction in mortality. And from a looking into the future standpoint, one study actually reported that there was an increase in revascularization referrals by 64%. And so you have to kind of figure that if once you develop this system, you're then not just taking better care of patients, but increasing productivity for your own institution. So this is kind of the brainchild of our program here at Honor Health, and this is based off Vinita Chandra's revamping of her limb salvage program over at Stanford. And so the idea here is that we have referrals sent in by PCPs, inpatient hospitalists, and podiatrists, and they all go to the wound care center and to vascular. Once they get plugged into that system, we have dedicated nurse navigators that are specifically for our limb salvage program, which then are able to keep track of these patients and manage their wound care clinic visits, their subspecialist clinic visits, which you can see in our multidisciplinary team listed on the left, and make sure that they're getting their studies all in a concerted effort to make sure that nobody is falling through the cracks. The other thing that we've been doing in order to make this even a more streamlined process is working with the EPIC team to make sure that there is a one-stop shop. So there's one order that you put into the limb salvage program if there's any concern for PAD. And again, using the Wi-Fi classification, GLASS classification, these specialists more in the community and in the ER are able to identify a patient who's at risk and make sure that they're plugged in with the correct consultants and imaging studies in a very expeditious fashion so that we can treat these patients as comprehensively and quickly as possible. Thank you.
Thank you.